My name is Dr. Lee Fong, and I'm going to give you a quick introduction to the COPD clinical care standard developed by the Australian Commission on Safety and Quality in Healthcare. So, why did the Commission develop this clinical care standard? To answer that question, let's hear from John, a person with COPD.
I was diagnosed in 2005 with COPD. Prior to that, I hardly went to a doctor. I ended up with a continuous cough. I couldn't breathe, I couldn't walk, and the family finally got me to go. He sent me directly to a specialist, lung specialist. I then found out that I had COPD and gave me 18 months to live. It was a big shock once we found out what it was, and it more or less changed your whole lifestyle. But I had to instantly retire from the Commonwealth Government, and we didn't do much travelling, but we did a little bit of travelling, and then it slowed down because of the problem. And today, I'll be lucky to go out to the letterbox and back without losing my breath. And it really holds you back. Your whole life has changed where you can't do much. And it's, you do see other people running around and you wish you could do the same, but unfortunately, that's the problem with COPD.
John is unfortunately not alone in this awful struggle with the symptoms of COPD. COPD affects the lives of an estimated 1 in 13 Australians over the age of 40. It accounted for half the total disease burden for all respiratory conditions in 2022 and was the direct cause of almost 7,500 deaths in the same year. COPD is also a leading cause of potentially preventable hospitalizations. What this tells us is that there's a lot of people with COPD who are experiencing exacerbations, who are probably experiencing that can't breathe feeling, for whom that didn't have to happen. Another reason why this standard was developed is the need to address the large differences in COPD care across Australia. Data from the 4th Australian Atlas of Healthcare Variation highlighted an up to 18-fold variation in hospital rates for COPD between local areas. Yep, that's 18 times the difference. People in rural and remote and low socioeconomic areas across Australia have higher COPD prevalence and hospital admission rates. In particular, Aboriginal and Torres Strait Islander peoples have double the prevalence, 5 times the hospitalisation rate and 3 times the mortality rate compared to non-Indigenous Australians. Other reports also show that approximately 50% of antibiotic prescriptions in admitted patients for COPD are inappropriate. It's also estimated that around 50% of people living with COPD don't even know they have it. So that's even more people who aren't getting the treatment they should be getting. So what's actually in the COPD standard? The standard includes 10 quality statements and a set of related indicators to measure local quality improvement. As with all clinical care standards, this is not a guideline. What it does is highlight key aspects of evidence-based care from existing Australian clinical guidelines, including COPDX and therapeutic guidelines. The idea of the standard is that if we can get these 10 aspects right, then we can do a lot to improve the quality of COPD care. I'll now give you a quick overview of the 10 quality statements following the patient journey from diagnosis. The statements fall into 3 broad groups of priority areas. Firstly, there's 6 quality statements in the standard focusing on managing COPD to prevent exacerbations and hospitalizations. Diagnosis and comprehensive assessment is where it all begins. We need to use spirometry to ensure an accurate diagnosis of COPD, and we need to do comprehensive assessments so we can be confident we are holistically managing people with COPD. Patient education and self-management are also critical. This means empowering patients with knowledge and strategies to manage and live well with their symptoms. Living well includes key preventive interventions such as vaccination, and for those who smoke, quitting tobacco smoking. Pulmonary rehabilitation is another intervention strongly supported by evidence. We need to find ways to get our patients with COPD into pulmonary rehab programs and then help them to maintain the benefits after they finish them. And of course, having access to the right medications for managing stable COPD also plays an important role. Maximizing the benefit of medication involves a stepwise approach to treatment and, very importantly, checking inhaler technique. When it comes to managing COPD exacerbations, the standard highlights two areas which are of vital importance, as well as appropriate pharmacological management. This includes oxygen and ventilatory support. And to complete the cycle, we need to have safe and smooth transitions of care and coordination back to the community after exacerbations. While the last statement in the standard addresses palliative care, I'd like to emphasize that palliation is not just about end-of-life care, but also about improving symptoms as much as possible and as early as possible. As a very important final note, advice about cultural safety and equitable care has been incorporated throughout the standard. So I hope this quick overview gives you a sense of what is in the standard and why. If we can refocus attention on best practice care for the diagnosis and management of COPD, then for people with COPD, we will improve outcomes and overall quality of life and help reduce that awful feeling of being unable to breathe. Please do visit the Commission's website to learn more about the standard and download the available resources. Thank you.